Great. So welcome, everyone. Glad that you could all join, and I'm sure we'll have some more members joining shortly. Let's see, I'm gonna, we'll get to review the meeting minutes from October as soon as we get a quorum. I just want to let you know that there's some vacancies on PHAB, and I expect one other member is going to resign, so we'll have another vacancy. But we, the chiefs of staff did interview one of our applicants, and it was a great interview, and I don't see any problem in their approval. So I'm hoping they'll be on board in a month or so. And there's another application in from another person who looks very promising and comes well recommended. So as soon as we get to see that and review the application, maybe we'll have another person on. But we still have vacancies. So if you know anybody who's really good and wants to be part of PHAB, please encourage them to apply. Okay, so I'm going to turn to the minutes because we do have a quorum now. Were there any edits to the October minutes that anybody wants to make, corrections? Hearing none, seeing none. Is there a motion to approve the minutes?
Motion to approve.
Thank you, Libby. Is there a second?
Second, Steve.
Thanks, Steve. Okay, could you enter into the chat window your vote on whether you say aye and approve or nay? Yeah, it's great. Thank you. I'll just wait till this tallies. Okay, great, wonderful. Minutes approved. Thank you very much. Perfect. On to our update from primary health, and we have Dr. Cassilier, who so kindly joins us every month to give us an update.
Farla, do you mind if we just go over the agenda? I'll just pull it up just so folks know where they might have comments. I'll just pull it up on the screen really quick.
Sure.
Okay. And I know we put the wrong name next to the primary health one, so sorry about that.
Oh, yeah, sorry.
But just
Switched.
but just a quick review of the agenda. And then Farla, do you want to talk about how you take public comments?
Yes, today, as always, we welcome the public to make comments during the meeting, as long as we still have time to get to our meeting business. So I ask you to please be concise. We'll take questions and comments during the meeting, and then after, following our discussion on the letter to the Board of Supervisors, because that's an important issue. We'd like to be able to get to the discussion of the letter and a vote on it. So let's leave it at that and see how the meeting goes.
And you can do a comment through using the raise hand feature to let us know. It's next to the smiley face at the bottom. If you click on that, you'll see the raise hand feature. And then you can also just put into the chat. You can either chat me directly or chat the group saying that you're interested in public comment, and I'll take down the queue.
Excellent. Thank you so much, Liz. Okay. Dr. Cassilier, we'd love to hear your update.
Am I up first, or is it?
You are.
Well, because they flipped the title, so I don't know whether you want primary health or public health.
No, we'd like you up first. Thank
Public
you.
health.
Okay, mine is going
Sorry
to be
about
very brief. I was asked to be very concise, so just two updates. with the numbers, case rate is about 15 per 100,000. We've been hovering over that for quite a while. There was a time when the numbers seemed to be going up, but they started declining again, but now they're remaining steady. Where we're seeing an increase in our cases is mainly in school-age children. We don't have any large outbreaks, but we do have a few outbreaks, but many of the cases are actually individuals that are exposed either at home or in the community, and then they're picked up in the school environment. Yesterday, the CDC approved the vaccination, Pfizer vaccination for 5 to 11-year-olds. So this week we started getting our first shipments. And so we're working to get those doses to pediatric offices and also working with our health system. So there'll be a lot of places where people can get the vaccination. It's very different from the rollout that we had last year. So plenty of vaccine. Everyone who wants to get vaccinated should be able to get vaccinated. Booster doses as well. We do have enough supplies. So right now, there are some general criteria for who should be prioritized for a booster dose. And so, and it's by self-attestation. And that's it. Turn it over to Sandy, or Steve has a question.
Just a quick one, just make sure I understand the 15 per 100,000. Is that 15 per 100,000 tests or 15 per 100,000 population?
It's per 100,000 population. With the tests, it's a percentage. And I guess some people do tend to mix those up. Our test positivity is about between 4 and 5%. And both of them are indicators that we look at, but they are different in that the test positivity, you're looking at how many positives in all the tests that you've done, whereas the case rate, you're looking at how many new positives or new cases among the population. So that's why it's per 100,000.
Great, thank you.
Any other questions? Thank you. For Dr. Kassirier? No? Okay, thank you again. So we'll turn our...
I think there's another hand from Dr. Oken.
Oh, I'm not seeing it. Oh, I guess because I can't.
It came late. Just a quick question, Dr. Kassirier. Will you be also getting a lot of cooperation from the schools and potentially having school clinics or anything of that sort for the rollout?
Yes, so with the school clinics, one is that many of the schools have actually been working with pharmacies to provide vaccination. So I believe that that will continue. The state also has a contract where they are going to send out teams to some of the schools, especially the ones in the high needs areas. So, and then we'll look at what's going on to see if there are any gaps that need to be filled up. Public health, because we do have limited resources, we are still continuing to focus on the community clinics that we have set up, where we will be offering the different types of vaccine, including the one for children, starting next week, as well as the flu vaccine and boosters.
Okay. Libby, you have a question?
Yeah, thanks. Dr. Kassirier, I was just curious if the county's considering a proof of vaccination policy for indoor dining or other venues that like some of our neighboring counties are, what the discussion is at this point?
Not at this point. It was discussed before, but I think the decision was that we'll wait and see what would happen with places like San Francisco and LA. And right now, we're not actively discussing it.
Okay, thanks.
Thank you again. Okay, we turn to Primary Health, Dr. Damiano.
Okay, good afternoon, everybody. Sandy Damiano. And I apologize, Farla, I sent you and Liz a handout like right before the meeting. So I don't know if you want to send that out or if you'll do that after the meeting, but it has a lot of these data that I'm going to discuss that's on the handout actually. So this PHAB report, I'm really focusing on the COVID-19. I'll start with juvenile. It's a very small program, so it'll be short. For the case data for the period of October 17th to 23rd, it had 61 confirmed cases throughout the pandemic. They had 46 tests that they completed for last week, 1 new case, and their census is 119, so pretty small. For their vaccination data, they vaccinated 86 people so far, and their incentive program began in mid-July, and so probation offers that incentive for them. For adult correctional health, I did show you the posted dashboard. We post weekly on the sheriff's webpage, and so you can see this is this is right during our outbreak period, but I'll kind of go over it with you. So for that particular week, we did 470 tests. We had a net increase of new cases of 24. You can tell there's a problem because in the intake quarantine, we only had 1 new positive case. So most of them came from the outbreak period. So for the outbreak, we did have press release by both health and from the sheriff's department. We reported an outbreak the week of October 18th. We had increased transmissions were begin to be noted on the October 20th dashboard. So on that particular day, we had a net increase of 75. And then you could see on this last dashboard, there was 24 cases. As of Monday, there were 60 new more, and then yesterday, 34 more. Those data is not on there. So we have a total of, I believe, 193 cases confirmed since the outbreak began. Some of those are due to intake quarantine, but the majority are outbreak. The minute we knew that an outbreak was in process, we began a variety of measures to contain it, most of which involved making sure that everyone was following our current COVID guidance. Additionally, we alerted our medical experts. I also alerted public health partner, our health officer, Olivia Kasiri, and we had shared with them that we're doing extensive contact tracing, quarantining, and testing. We also had some advice from her on some serial tests that we're doing in some of the large pods. So our new dashboard should be out tomorrow afternoon. That's usually when we send it to the sheriff's office. So it'll either be posted November 4th or November 5th, but we try to post right away. In addition to the measures I talked that correctional health staff are doing, the sheriff's department is also has increased, I believe, people on home detention. They're looking at some other measures. The health staff, the medical staff did come up with a very extensive list of people who are considered medically vulnerable. And that was a list of diagnoses prepared by our medical expert during the last outbreak. So we just used that, repopulated it, and sent that over for consideration of compassionate release. So we don't know to date yet how many will be released on that basis. On November 1st, we also had an inmate death, which you probably heard about from the paper. We also did a press release on that. This appears to be COVID related. It was an older gentleman in his 70s. He had multiple significant medical conditions. He was hospitalized since about October 25th, had a cardiac arrest. This person was fully vaccinated. So it really goes to tell you about the vulnerabilities for people, older adults, as well as those with extremely complex medical conditions, the vulnerability despite the vaccination. Yeah, I'll pause for a minute on that. So what happens during an outbreak, particularly in the branch jail, which always is a real concern for me, is it's not a celled environment. There's open dormitories. It's very difficult once that process is found because you're already too late by the time you've found positives and you start contact tracing and you start quarantine. Every time we get a positive, we might have dorm lockdowns or housing lockdowns while they're on the appropriate types of quarantine or isolation. So I fully expect we're going to see a lot more positives in this. This kind of has to run its course. For inmate vaccination incentive program, I believe I talked about this before. It began in July. We enhanced the incentive. I think doubled it basically. And then we further enhanced it on October 25th as one of our protective measures for inmate workers. And those means are below. What happens is they don't get cash. The money is deposited into the inmate's account so they can use those funds in the commissary or for phone card or whatever they'd like to do. So we're really trying to push the vaccines. We started the program because all of the patient education that we provided, the FAQs, none of that seemed to be working in terms of having a robust response. So this was our other means to try to lift up the vaccination program. And I don't have it for this particular week, but I think we had over 50 vaccinations that week. We are offering COVID vaccines, we are offering boosters, and we are offering flu shots for all inmates and staff.
Sandy,
Yes.
that sounds great. There are a couple of questions and I think they're on the earlier section. So could we pause and
Oh yeah.
okay, so Phil and then Steve, your hand up.
Yeah, thanks, Dr. Damiano, for the update. And I'm glad to hear that you all are taking action to see who can be eligible for compassionate release. That sounds like a really positive move. If we could scroll up a little bit, I was just a little confused on the dashboard data because I see the net increase data, and then so I guess this doesn't include the most recent numbers that were.
No. You're absolutely correct. So this one we post once a week. This one has 24, but if you go into my little narrative there, I didn't write it all down, but that has 193. So when I look at those dashboards on 10/20, there were 75 net new, 10/27, 24 net new, Monday 60, and then there were 34 yesterday.
Gotcha. So the net increase refers to the week, and then
yes.
In the outbreak section, you'll be portraying kind of the cumulative cases for this current outbreak, correct?
I'm trying to. So tomorrow, when we list our other dashboard, it'll have the week from October 27th, and the 193 is rolling since it began the week of October 18th.
Gotcha. And then my other brief question is just, so the vaccination efforts are obviously greatly appreciated. The other side of that coin is kind of vaccination rates among sheriff staff and kind of mask compliance among sheriff staff. I know I've heard a lot of concerns about poor mask compliance by the custody staff. And I'm just curious what mechanisms are in place to ensure, I mean, especially with this ongoing outbreak. I know your intake screening is very robust among people who are incarcerated. So that leads me to believe that there's a high chance that the outbreak came from custodial staff. And so I'm just curious kind of what efforts are being made there, or if it would be at all possible to get some transparency regarding vaccination rates and COVID rates among sheriff's staff, because that's obviously the other side of this coin.
Yeah, no, those are all good questions. So as part of our outbreak, I guess, review, we had a number of corrective actions, and some of those had to do with adherence to regular COVID protocols, as you're saying. And the sheriff's office did take immediate action on some of the items that you mentioned. So those are in process, making sure everyone's masked. No one's going to events like appointments or, for any of the programming without masks. And we do have weekly meetings with the command staff. I lead those for the COVID part. And then there have been multiple meetings per week with the command staff and our infection prevention person as well. We did also have a meeting with Dr. Kasiri and the command staff and our nursing director, just to confirm some of the COVID protocol in terms of housing. So those are all in place. In terms of the vaccination rates, for the health staff, it's about the health staff, if you include health, medical, the mental health, and the on-site admin in the jails, it's about 95%. So we're really good on our side. I think you probably should get the information on the sheriff's vaccination rates from that office or for the COVID infections.
I think that would be super helpful. And then just the one last comment is I've heard a lot of concern about kind of access to masks among people who are incarcerated and people kind of having to wash their cloth masks in the shower and having the same mask for weeks and weeks on end. And so I just want to make sure that we're providing adequate access so people can not be reusing their filthy masks over and over again.
Okay, was that a recent comment?
It was, yeah,
Okay.
Someone who's currently incarcerated.
Oh, from currently. Let me pass that on to the corrections chief. It shouldn't be happening. There should be sufficient supply of masks. There's no barrier to that.
Perfect. Thank you for that.
I will pass that one on, and also the question about vaccinations.
Okay, so because we're running short on time, I'm going to ask that we have one question per person for now. I'd like Dr. Damiano to get through her her update. Let me just ask a couple of quick questions, I hope, from the chat. There's one about which items are the sheriff's staff acting on. I'm not sure what that means. Another one, you mentioned the steps taken to request compassionate release of those who are medically vulnerable. How many people are on that list? And is there anything we can do to advocate for or support those steps? That was from a board member.
Okay, so let me see if I can remember all this.
Sorry.
So for the list of patients, it's a super long list because we're blind to charges. So what we did was just pull by clinical diagnoses and send those persons over, that list over to the council and to the sheriff's department. And then they look at it with charges and make the determination for release.
Okay.
Yeah.
And just to get a sense of numbers and what kind of relief that would put in terms of space and crowding in the jail, are you able to share what the number is?
It was hundreds.
Okay.
I don't have it, I'm sorry.
Okay, thanks.
All right, so Steve, I'm sorry, I see your hand has been up for a long time. Can we take one last question and let Sandy try and get through the rest of her update?
And my question is, I just have the one question, which is, you've got currently, it says 75 inmates in custody who are positive. Is that number included in Dr. Kasiri's 15 per 100,000 calculation?
I think your question is, do we count the jail cases in our case rate? Yes.
Yeah.
Good. Okay. All right. So Sandy, can you please finish your update?
Okay. All right.
Thank you. Sorry for this.
If we go to the next page, please, Liz. On the on vaccination date for inmates, we vaccinated 2,429 inmates so far. We do use all 3 of the types of vaccine. When we looked at a point in time count, which we looked at on October 20th, and I'm doing those once a month because it's a data pool, at least 30% of the census was vaccinated, had completed the series. And then if you look at the point in time by length of stay, you can see that of those who've had at least 1 dose, 85% have been in custody for more than 60 days, meaning the longer you're there, the more likely to get vaccinated. So those are just point in time counts that we have. I do want to say one thing about the inmate vaccinations, the point in time count. There's a box that says refused and has a number on those. That's not a true refusal. What happens is we changed our documentation process for nursing. So I don't know if we should include that or not, because everybody's been offered and we changed how they're documented so we can pull the data better, because it was in notes before that we can't go back and correct. We are under the state public health order for correctional and detention facilities. I've mentioned this before. The order's in effect and it requires all healthcare workers, admin people, custody, and inmate workers to be vaccinated and show that vaccination verification, or you have to have a qualified exemption and weekly testing. The weekly testing is done on site. There's 2 clinics at each jail facility for staff to participate in. Those are run by public health, which we really appreciate because we're doing all the testing of all the inmates all the time and contact tracing. So this is also a really big effort, but I can tell you that this is mostly custody and inmate workers that are getting the tested because our vaccination rates are so high for health and mental health staff.
Thank you so much. All right, so there were a couple of other questions really quickly. Let me see.
It was Aparna, and I'm sorry if I'm not saying that correctly, but in the queue, it's Aparna and then Robin.
Okay, I think, yeah, all right.
Can I go ahead and ask my question?
Yes, please do, Aparna.
All right. First, let me just introduce myself. I'm Aparna. I lead the COVID in Custody project. We track COVID-19 cases and testing rates for carceral facilities across California. I want to highlight some major concerns my team and I have had regarding data transparency from Sacramento County. And since Dr. Damiano is on the call as well, I think this is a great opportunity to disclose some of these issues. So my team and I have been filing public records requests for very basic data on cases testing for jail staff and for vaccination rates for the Sheriff's Office, as well as the Department of Health Services. And the data that we have received is not at all conclusive. It says nothing about how many staff are vaccinated and how many staff are being tested, which is a major concern. So I want to provide some 3 concrete data issues that I hope can be addressed. So first, for the jail staff, we have not received any data on the number of cases and testing that is going on. Pertaining to the July 26th health order, there's no information on compliance rates. So we don't know how many staff that need to get tested are actually getting tested. Coming to vaccinations, the data that we have received is aggregated between the healthcare as well as the Sheriff's Office staff. We don't see how many Sheriff's Office staff are vaccinated, period. All our PRA requests for Sheriff's Office vaccinations gets redirected to public health, and public health gives us an aggregate report between healthcare and SSO staff. And added to that, there is no denominator, so we don't know the vaccination rate. So those are the 2 primary concerns with staff. For the incarcerated population, the data is not disaggregated between people who are currently in custody versus those who've been released. So all of the numbers that we're seeing right now in Dr. Damiano's report is just the total number of incarcerated people who've received vaccinations, but we don't know how many people in custody are vaccinated. There is no vaccination rate. So without that, we have no idea what degree of immunity actually exists in these facilities. And lastly, with the July 26th health order, there is no information about compliance. And without, again, data on vaccinations for jail staff, vaccinations for the sheriff's office, and vaccinations for public health, very concrete numbers, there's no way for us to know how compliant the jail is being with the July 26th health order or the August 19th health order. So I would really urge folks on the board to push for data transparency. I have been filing public records requests since May. These have not been honored. The data that we receive is very sparse and inconclusive, and it is a serious problem given the current outbreak. Thank you.
Okay, I can't respond to all of those, obviously. So the Sheriff's Department will need to provide the data for you on their vaccination rate and on their testing. We do not have their verification data in the Health Department. We were providing some more aggregate data of people, either health or sheriffs tested on site. But that's not the whole picture of people being vaccinated, because people also receive vaccinations offsite or within their doctor. Once the health order took effect in August 19th, we have a system called Qualtrics where people have to upload their vaccination verification or their exemption. We do use that for all of our medical staff, and that's where we're getting the 93%. We use UC Davis for their vaccination data, and that's where we get 96%. So we're aggregating that. But I don't keep the Sheriff's Department information. On the inmate vaccinations, you're absolutely correct. We do put in all the vaccinations throughout the entire pandemic, but we are also now doing point in time, which is where we got the 30% have been vaccinated. And it does have the total population incarcerated of 3,155 on the particular day that we ran that data report. So we do have some of those elements. But again, because we're a split department, the sheriff is under their own department and adult correctional is under health. We do use different systems for the vaccination verification, and we do not get their test results. Public health does, but we do not. So I hope that clarifies some of the questions. I couldn't track it all.
Sandy, I'm going to ask, do you have time to stay on for the entire meeting?
I have to leave promptly at 1:30, but yes.
Okay. Because we're getting quite late. This is all incredibly important, but I don't have the ability to reschedule the agenda right now.
Okay.
And I would like very much to get to the letter. So I'm going to ask if it's okay with everyone to hold the questions. I have the questions that are in the queue from Robin and Liz Blum, and I appreciate Aparna, all of your comments, and we'd like to discuss this further, but I'd also need to get to the agenda. So if it's okay with you, I hope that we can manage to address this later on in after the board addresses the working committee's letter and a potential vote. And that letter is also quite relevant to the discussion right now. So I hope you can all stay on as we proceed through the meeting.
Your question will be, I have taken them all down, they will be in the notes, as well as Sandy's document that we pulled up. And Liz, let me know if she's okay with us moving forward. And Robin, I will connect with you as well to make sure that, I know you submitted that question in there.
Yeah, and Aparna, perhaps if we don't get to address some other issues with you, we can have a conversation after the meeting. So let's move on. Thank you, everybody, for your participation in this discussion. Next, we turn to Stacy Saez from the Division of Public Health, the Sacramento County, looking at the STD update. So I thank you for being here. And Liz, can you bring up Stacy's presentation? And
good afternoon. Can everyone hear me? Just want to make sure that my sound is coming clear.
yes. You're coming
Okay.
in.
Okay. Yes, I'm Stacy Saez. I'm the HIV and STD as well as Health Education Programs Manager. And because you guys have a lot on the agenda today, I normally do a much more extensive epidemiology review and update for you all, but I abbreviated it this time because of the tight agenda, but also wanted to give you some updates on actually our program activities. And so I'll quickly go through this because it sounds like you guys have a lot of important things on the agenda. Liz, if you can advance the slides for me. Liz, am I controlling it or are you doing it?
Do you see the first slide?
Yeah. Mm-hmm.
Do you want me to go to the next one?
Yeah, is it on presentation mode?
Oh,
Looks like
it
it's-
is, but maybe it is on my side, but maybe it's not on yours. So let me just try again. Is that better? Are we on the HIV slide?
Yes.
Okay, great.
All right, thank you. So really briefly with HIV cases, go to the next slide. As you all know, HIV cases, for us anyway, have pretty much remained in a kind of plateau. So when you look at the cases all the way over to the right, you'll see that for the last 5, 6, 7 years, we've been really kind of staying stable. I will say that with those cases showing from last year, we are looking at only data up to 2019 because there's always data delays with getting the HIV information. And so I want to say just because of what we've been observing among our community-based organizations as well as our STD clinics, we are seeing an uptick in our number of HIV cases that are being diagnosed. And so, you know, I'm anticipating that the data is going to look a little different in a couple of years when we're actually looking at the 2020 and 2021 fiscal years. But again, because of how the data is managed both at the local and state level, there are data delays. And so I just want to put it there. It looks like we're doing a good job of you know, going down, and certainly the AIDS cases have gone down with the medications, and people are living with it more as a chronic disease. But unfortunately, like I said, I do think we're going to start seeing a bit of an uptick in the next couple of years. Liz, I'm sorry. And so again, this is the HIV infection. You'll see that that's plateaued as I was describing. And again, this data is only up to 2019. So I'll give you guys an update when we have new data. Next slide. And this is just, I kind of went over these already. When you look at our AIDS cases, kind of stabilized there as well. You know, and this is something that we really want to make some impact on, because you are seeing, you know, this plateaued level for both for the AIDS cases as well as the newly diagnosed HIV cases. And so some of the things that I'm going to share with you in terms of some new programs that we have are meant to address the fact that these cases seem to be, you know, kind of stable and plateaued, and we're not making a lot of movement in terms of having a true decline in our cases over the past several years. Next slide. So this is just a slide to illustrate kind of where the HIV cases are related to age. And so what you'll look at in the new newly diagnosed HIV cases, about 35% of them fall within the 20 to 29-year-old age group. What's important to understand about that is if they were diagnosed when they were 20 to 29, that means they were likely infected earlier. There's a strong possibility that they would have been younger. And so that is concerning for us because we are seeing more cases among young people. And we've actually had several come in our clinic this past year. We diagnosed some 18-year-old, 20, 21-year-olds. And so that number is kind of concerning for us. And we are doing specific interventions to try to address that among the youth population. So next slide. When we look at HIV cases, it's still primarily a disease among men, as we say that, particularly MSM men. But you will see that there has been some decline. And for us, the numbers are related to what we consider high-risk heterosexuals. If you look back in 2010 through 2014, we were really seeing an uptick among the heterosexual population, the high-risk heterosexual population. And so that has started to decline. I can't exactly give you an explanation for what that decline is. It could be, you know, some of the folks that are high-risk heterosexual may be in the other, where a transmission source may not have been identified, but I'm hopeful that this is because of some of the interventions that we've been doing, along with some of the people utilizing PrEP, pre-exposure prophylaxis, which prevents HIV infection. Next slide.
There was a question in the chat, Stacy.
Oh, I'm sorry, I didn't see it.
That's okay. It says, do you mean people assigned male at birth? Where is the trans population in this graph?
So in the graph, because they represent such small numbers overall, this is not indicated in this particular graph. But when you look within the transgender population and look at them alone, you will see higher rates of HIV infection among that population. And so they are a priority target population for us in our various interventions, including our clinic efforts. But again, because of how this data is extrapolated, it's such a small number that it's not graphed here on this particular graph. But again, it is a population that we have some very clear prioritization of activities with. And so it's not that they're not an important audience for us to be addressing. It's just that they're not represented on that particular bar. I'm sorry, I'm seeing other questions. No, again, I'm sorry, I'm looking at the questions. No, again, the MSM population that is shown here is not representative of anybody that would be identified as being in the trans population. Okay, next slide, if I answered that question. What I wanted to show here is that people living with HIV and AIDS that are enrolled in our YN White care program have some better outcomes than maybe the general population because of the wraparound kind of services that go on in the Ryan White care program. It really is a kind of the gold standard in terms of HIV care, where many resources are provided in addition to medical care, dental, transportation, mental health services, alcohol and drug services. Because of that model that Ryan White follows, we see good outcomes, and we also see very good outcomes in compared to the state. So when you look at our Ryan White clients, 85% of them are quickly linked to care. 54% are retained in care. That number looks low, but really it's kind of a definition that the federal government uses to describe retained in care. And so even though that looks like 54%, as people are living and being more healthy with HIV, they don't tend to have to come into the for appointments very often. And so this criteria really is how many people come and are seen twice a year in a clinic when they capture this number. And so again, if you're living healthy with HIV, there's not as much need to connect with your care. And so this number looks a little distorted just because of what the definition of that is. But what we want to look at here too is that our clients, about 72% of them are virally suppressed. Obviously, we want that number to be higher, but again, when we are looking at the outcomes of the state and also looking at the general population of HIV clients in Sacramento, the Ryan White clients do better with their outcomes, their health outcomes. Next slide. So now we're going to take a look at syphilis. And syphilis remains a ever-increasing concern and problem for us. And so I'll give you a little data on that. Let's go to the next slide. So when you look at this table, what we're looking is at 2019 and 2020 data. And you can see that we have a significant number of primary and secondary cases being diagnosed. These numbers have increased steadily for the past 5-6 years. We've seen, dramatic increases annually with these cases. But what's concerning about the primary and secondary cases, of course, are that this is when someone is most infectious. And so these are the clients that we are trying to do really intensive effort to try to get them treated early and diagnosed early so that we can prevent further spread. Now, the 2020 numbers, when this was done by our epidemiology staff, this was earlier this year. And so this count may not be completely accurate. The numbers are probably higher than this, but at the time that this presentation was created and these numbers were run, this is what the data was. Again, any updated information, I'll definitely pass on to you all. And then what you'll also see down here, which remains a very serious concern for us, are the congenital cases. These congenital cases are upsetting because they're 100% preventable. But what that requires is us getting to the women that are pregnant quickly and getting them treated before they deliver. And so we're doing a lot of efforts to try to address that and mitigate that number. I do want to say, though, that our numbers are reflective of what's happening all across the state of California. The state of California has some of the most significant cases of congenital syphilis in the country. At one time, we were 1/3 of all new congenital cases in the US were in California. So we're having a particular issue here with that. And there are a lot of intense efforts that are being provided to address this, both at the state and at the individual health jurisdiction level as well. Next slide. Again, this is just to show the increase in cases, the significant increases from 2011 to where we are now. Again, this 2020 data is probably higher than this, not reflecting data that had not been calculated in the state by the state when this was done. So I know that that number is higher than that. It's probably closer to our 2019 data, if not higher. But this is what you see in terms of the trends. Next slide. When we're looking at,
Stacey, there are a
yes.
couple of questions.
Oh, I'm sorry.
No,
Okay.
no, I'm sorry to interrupt. I think
That's okay.
I think that we'll take some questions now. And if we don't have time to get through the whole presentation, I would love to have you come back in December. Okay,
Okay,
is that
absolutely.
that's fine with you? Okay. Lori Miller had a question. Lori, do you want me to read it off the chat or would you like to chime in? And Liz will unmute you.
Hi, Stacy. It's Lori Miller with
Hi,
Substance Use
Lori.
Prevention and Treatment. Good to see you. Yeah, my question was, a couple of years ago, individuals with HIV were considered a priority population, meaning they had a federal priority status to get into substance use treatment as a priority. And then I was told a couple of years ago that that was removed due to the case rates going down or leveling off. So could you just verify if there are still a federal priority population for us, just so I'm making sure that, I am prioritizing this population if that is the need?
In terms of the, it depends, not just general substance users, but intravenous drug users definitely remain a priority, both at the federal and state level. So that's what they did, Lori, when they eliminated the HIV set aside, which might be what you're thinking of when that happened, it wasn't that those audiences weren't a priority, but the way that the feds were looking at it was that if they were using AIDS cases to decide which states should still receive that funding. And when you look at people having better outcomes because of the HIV medications, obviously our AIDS cases will have gone down dramatically, which is why we were no longer eligible for that funding. People did push back and say, well, you should be looking at HIV cases because that's really how you measure what's happening in terms of the transmission. However, that's why we lost that HIV set aside that was part of the substance, part of your funding that you subcontracted out with us to do. That was actually, removed from California because of the way they were looking at the data. But intravenous drug using populations, injection drug using populations continue to be a priority, like I said, at the federal, state, and local level.
Great, thank you, Stacy.
Was there an additional question?
I think Sarah, one of our public comments, our member from the public has a question.
Hi, thank you. Can you hear me okay? Can you hear me?
Yes.
Oh, great. Hi, thank you for this. I guess I have one question and then one request if you're going to present again in December. So my question to you would be if you could talk a little bit about geography in the county, where you're seeing higher prevalence rate and where you're seeing lower viral load suppression and the like. And then my request for December would be that it would be really fantastic if you could present the data according to the HIV cascade, right? So if you could present the data looking at infected, diagnosed, linked to care, retained in care, on ART, and virally suppressed. Mm-hmm. So that would be really fantastic because then that would allow us to be able to see the flow, but then also look at where are those leaks, right? Where are the leaks in the cascade and what are maybe even have some information about sort of what are those interventions for those leaks and what does that look like as you go through your data. And I new back to Sacramento, and full disclosure, I've worked in HIV for 30 years and it breaks my heart to see a viral load suppression rate of 73% in a county such as Sacramento. Our goal, I think internationally is 95, right? 95, 95, 95. So to hear more about sort of what those interventions are at some point would be really fantastic. But I think the starting point would be to look at the cascade data. And then also the syphilis rates are really concerning when we think about, I was thinking 2020, it wasn't everybody at home, I don't know, but to see sort of these rates that are going up, and we know that syphilis coincides with HIV often, right? And if you're having congenital syphilis, I would worry again. My hope is you've had no perinatal infections in the county for years. Correct me if I'm wrong, but I'm hoping that we're not going to see any big backward trends. But thank you again for presenting this, and I look forward to hearing more. Thanks for your work and your service.
Hi, Stacy. It's Larissa.
Hi, Dr. May.
Larissa.
Hello. Hi, everyone. I just wanted to say, I just wanted to point out the efforts that we, in partnership with the county and with our FQHCs, have been working on at UC Davis Medical Center to really capture some of our vulnerable populations. I mean, I think the challenge is that if you don't target the underserved, you don't target those, that are using substances, then you're missing the ones that are at higher risk, and they're not seen in traditional care settings. They don't access care in traditional care settings. So I really think, and I know the state is working on this, expanding some of these ED programs would be great. Unfortunately, it requires a lot of infrastructure and support, particularly for the linkage to care piece. I think we are breaking down some of the stigma and the other barriers to providers wanting to do it, but the linkage to care piece is still a huge challenge. And I'm not quite sure how to do that, how to get that more commonplace. But there are other parts of the state that are also focused on this. Fresno County and some other places in the Central Valley, which has the highest rates, I think, of syphilis, and even have some like general screening programs that are going on in the ED for all comers. We haven't quite gone that far at UC Davis. I can tell you that in any patient with a positive chlamydia or gonorrhea test, about 10% of our adult patients are also positive for syphilis, most of whom didn't know it, and many of whom have been untreated. And our program actually potentially prevented 9 cases of congenital syphilis by treating pregnant women who otherwise did not access care elsewhere. So we're hopeful, and we're doing some more things in the ED to try to capture those pregnant patients that are coming in that are out of prenatal care. Because about 30% of our patients that present with pregnancy at UC Davis are at our ED are out of care. So they're not getting prenatal care. So we're trying to capture more of them there. Again, the challenge is linkage to care follow-up and the complexities of treatment of syphilis that many ED providers and others don't feel comfortable, managing, and also which requires, a lot of coordination with public health. So our program kind of takes that burden off the case, but it would be great to see that expand. And also expand, we're partnering with our Bridge program in the ED too, to also target testing and screening in those patients that receive substance use intervention treatment in our ED and in our hospital setting as well.
So this sounds like it's ripe for a lot of discussion.
Yes.
Definitely. And I think it's just terrific that you can come back, and next month we can have a longer discussion and learn more about other STDs that I know are in your presentation.
And I know I need to wrap up, and I can definitely come back. I do want to acknowledge, Liz, if you could forward several slides, I'll tell you when to stop, and I just want to at least show you guys this, because you all were very instrumental in some of the new interventions and opportunities that we are getting to address some of these issues. If you can stop at this slide, what I really wanted to just quickly show you guys, it's like feast or famine, right? There, for many years, there were not new investments in HIV or STD prevention efforts. And so it was really stagnant. But over the last several years, we have written so many grants, and there have been so many opportunities at the federal, state, and local levels. And so what you're looking at for us now is that we're working with an annual budget of about $9 million to address this, and we have several new programs. And so some of the questions that you all were asking in terms of what we're prioritizing in terms of interventions, when I come back, if I can have a longer time to really kind of go through what some of these programs are, these new grants, you'll see that we have a specific allocation for a syphilis congenital syphilis intervention that is to do enhanced case management of pregnant women. And so I can give you a better overview of exactly what we received in funding and what we're doing. I do want to thank PHAB because you all were instrumental. Liz, if you can go to the next slide, instrumental in helping us to secure the new staffing. For that, there was a time when we got the grants, but we're not being allowed to request the staffing. And PHAB, along with other community advocates, really pushed back and said, "Hey, if we have the money, why can't they get the positions?" And so I want to thank you all for this, because what you see here is that we've had new CDIs added. We've had 4 new CDIs added, and we now have 8 CDIs, as well as a senior CDI, 2 health program coordinators, including the permanent clinic manager for our sexual health clinic were added. We have a new health educator, a new linkage to care coordinator, who's a health educator assistant, 2 new medical assistants, a new public health aide, and we have additional staff that we anticipate because of this new funding to bring on. So we have a lot of resources now to really kind of move forward with doing some more intense interventions, as well as some more innovative interventions to address all of those audiences, the underserved. Our Ending the Epidemic funding really is targeting the unhoused populations, intervening youth drug users, as well as the audiences that have typically been vulnerable to HIV. And so there's a lot of exciting things. As much as I was showing you the data where it's still showing negative things, we have some tools to move forward to try to address that. So I can, the rest of the presentation was kind of describing some of those interventions and what we're doing and how we're prioritizing, including some incentivized viral load suppression activities that we're doing. So I'd love to come back and kind of get into the meat of that with you all at another time.
We will ask you back in December. As I said, there's a lot of interest in this. I want to congratulate you. It's the success in garnering more funding has been amazing, and we are just delighted to be able to help in that and support you in that. So everybody I'm sure is eager to hear the rest of the presentation, and you can have more time in December. I will definitely schedule it for a longer session.
Okay, thank you.
Thank you so much, and we'll talk about that after the meeting or offline, and we'll arrange it. Thank you, Stacy. Terrific.
You're welcome.
And thank you for the participation in this discussion. So now, quickly, we turn our attention to the next agenda item. And this is a letter. I'm going to let Libby and Phil discuss this segment of the meeting. They'll explain the letter and ask for questions, and we'll get to see if we have, we'll get to a vote today. So please come prepared, ask questions, and we'll try and work on making sure that the letter is, that everybody can support this letter. So Libby or Phil?
Hi, everybody. So this is kind of building off of our presentation last month that kind of provided an overview of our newly formed jail health committee. This letter is kind of the initial culmination of several months of work and countless hours. I just want to shout out to the jail health committee for all the work they've put into this. So as I mentioned, we met with multiple stakeholders. We've kind of drafted these ideas multiple times and kind of distilled what was originally, I think, an 8 or 9 page document into what you see right now. So we tried to be as concise as possible. I know that you all should have received this letter ahead of time. And so I just want to start by seeing if there were any clarifying questions or any particular concerns among PHAB members before we kind of go through the letter. Okay, feel free to raise your hand if any of those come up, or just shout out. So I'll just kind of go through this briefly because you all should have access to it. So anyway, the first couple of paragraphs are just kind of providing background to the Board of Supervisors, announcing that we have kind of formed this committee. We've met with several of them already, and kind of highlighting our objectives to kind of focus on the public health implications of incarceration in our county. Second paragraph really highlighting some of the issues that we see and the poor health outcomes that are have been highlighted by the Mays consent decree, which the county is currently under. And then with the recent publication of the monitoring reports, kind of the overall slow and pretty limited progress that's been made to date. And then also kind of describing how, the issues that we are hoping to address are definitely beyond the scope of just kind of the healthcare services within the jail, acknowledging that Dr. Damiano has been putting forth a ton of effort to kind of improve the health services, but that ultimately our jail is overcrowded and we have an excess incarceration rate for our county, and that is really just making this situation frankly untenable. And so hoping we can have a more coordinated effort among multiple agencies within the county to improve health outcomes for this population. So this paragraph is kind of just highlighting the consent decree, the contents of it. I'm not going to go all the way through that. You can read it there. And then, as with multiple sectors of our society, COVID has kind of highlighted a lot of our vulnerabilities and exacerbated disparities that already exist. And we are seeing that predictably in our incarcerated population. So, and then this next paragraph is calling out the Board of Supervisors declaration of a public health racism as a public health crisis, and identifying specifically the implications for our incarcerated population in which people of color are disproportionately represented. So our overall call, as we mentioned there, is kind of a concerted effort to reduce the jail population in a sustained manner. And then we have multiple areas of kind of specific focus that first of which includes transparency and accountability. As we kind of already discussed on this call, there are a lot of concerns, particularly around the lack of transparency from the Sheriff's Department that oversees our county jails. There are intensive monitoring efforts that are involved with the Mays consent decree. There are multiple groups of court-appointed experts that conduct these monitoring activities. Their reports are very, very detailed, very thorough, very dense, and pretty inaccessible. So one of the aims of this is to kind of develop these publicly accessible dashboards that kind of provide summaries of kind of these areas where there are deficits, areas where progress is being made, and areas that are kind of vulnerable to not being in compliance. And then along with that, hopefully some public hearings where we can get some summary so that the board, frankly, the Board of Supervisors and the public can better understand kind of the issues at hand and hopefully respond accordingly. And then we also include kind of a preliminary list of indicators here that we were immediately concerned about, but then allude to the fact that this list is not exhaustive and we should kind of develop this list of metrics in collaboration with multiple other stakeholders and advisory boards so that it can be comprehensive and meaningful. And then there are some expert consultants that are currently examining kind of alternatives to incarceration and space solutions within the jail, as the county's not going forward with the previously planned annex. And we're anticipating that those findings should be published. We've been told probably Q1 of next year. So we are kind of requesting public hearings around those so that those solutions can be elevated and hopefully discussed. Next point is the Public Safety and Justice Agency. which was formed over the summer, and the deputy CEO recruitment is currently in process. We wanted to highlight the importance of kind of health equity and an expertise in public health and cross-agency collaboration, and specifically state that we hope this is not a person who has a law enforcement background, given the kind of diverse nature of this role, the broad scope, and hope for collaboration with other agencies, and really the need for somebody with expertise kind of outside of the limited scope of law enforcement. And then also with regard to the makeup of the PSJA, hoping that there is input from multiple stake members within the community, within the county bureaucracy, and specifically input from impacted community members, people who have experienced incarceration and their families. In custody deaths, as we heard, there was this likely COVID-related death that was announced on Monday. There have been a few other deaths in the past few months. There have been longstanding concerns around transparency in this space, with delays in reporting deaths and a lack of transparency around causes and circumstances and things like that. Many of these concerns were highlighted in the Inspector General's most recent report, and underscored in our conversation with the Inspector General. So these recommendations are kind of in line with those concerns, and specifically pertaining to making sure that loved ones of the deceased are promptly notified and kept up to speed, because that historically has not happened. And then specifically a request for kind of root cause analysis and really just a culture of learning that doesn't appear to exist within the sheriff's office currently. And then again, in the spirit of transparency, requesting kind of a dashboard or a summary of in-custody deaths. This information is not readily available, and we've kind of spent extensive effort like trying to get that information, and it is kind of inconsistent and delayed, and by the time it is published, it's kind of past, and so it's hard to kind of find that in a consolidated way. So I think it's really important that we kind of benchmark that among other counties, so we can know where we stand, because the data that we were able to pull together highlights that the mortality rate among the incarcerated population in Sacramento is, I think, the third highest in the state, and the only counties that are higher are like LA County and Orange County, which obviously have substantially higher populations. So that per capita death rate that we're experiencing is very concerning here in Sacramento. So we want to make sure we can monitor that and hopefully ameliorate some of the causes.
Thank you so much. That's
yep.
Great. A wonderful recap of this. I think everybody must realize how much work this committee has been putting into to this effort, and we are so grateful for all the work you've done and the excellent work at that. So I would just like to leave enough time for questions or comments before the vote, and to circle back to the issues, questions that had come up earlier that we postponed. So Steve Heath has a hand up.
Just the question, I'm a little confused. Is this a letter proposed from the committee or from the Public Health Advisory Board? The third paragraph, for example, says our committee shares. It's written as if this is a letter from the committee. So, I don't want to wordsmith and nitpick. I just like clarity on what we're voting on.
Absolutely, thank you. So this is a letter drafted by the committee on behalf of PHAB. So we will be voting as PHAB to submit this letter as PHAB, as a product of the work of this working committee. So that should probably be rephrased. I agree.
Very, very good point. Thank you, Steve. Libby?
Yeah, thanks, Farland. Thanks, Phil, for the really excellent overview. You summarized everything super well. I just want to make sure it's clear to those who are not in the working committee but are on PHAB that there's actually kind of a longer term strategy here as well. I think we've uncovered a lot of challenges and opportunities in this space. Phil made allusion to this, but we really feel pretty strongly that the long-term public health solution here is reduction of the jail population. There's a lot of great county programs happening already around diversion, mental health services. We want to go deeper on that in a subsequent letter. So just flagging for others on PHAB that this working committee will extend. I think we have a lot of great work ahead of us with the county to continue figuring this out. And that's why what you're seeing here are more kind of short-term immediate solutions that we feel the board and other county agencies can respond to immediately while we continue to work on the long-term vision.
Thank you so much. Any other questions before I ask for a motion to approve this letter?
Liz here, just to Steve's comment, was there a change requested within the letter?
The beginning of the third paragraph, our committee. Maybe we can just say PHAB.
Yeah.
Thank you.
Yeah. Thank you, Liz. Okay.
And Liz, let's just do a scan later and make sure we catch any other similar references. Happy to do that for you and send it to you.
Mm-hmm. Excellent.
Okay.
Okay.
Can we make a motion to approve the letter?
Motion accepted. Is there a second?
This is Tina. I second.
Thank you, Tina. All right, can we vote in the chat? Aye or nay, or yes or no, whatever you prefer, to accept the letter as is and send it to the Board of Supervisors. Okay. I see all right, so we have enough votes to approve the letter. And thank you, everybody. We will be making the appropriate change that Steve suggested and checking the letter and then sending it off to the Board of Supervisors. I thank everybody for that. As Libby said, this is sort of just the beginning. And I think we'll be doing our duty, definitely advising the board on this such important issue. I don't think we've ever looked into any issue with such effort and depth. And I think the committee is well equipped now to make more recommendations and keep this work going. So thank you. Obviously, it's a very critical work at this point in time.
Farla, if I may, we do have another spot on the working committee for a PHAB member and hoping to include additional community members. So if anyone is interested, please reach out to one of us directly and we can talk about what that looks like. But we would appreciate any additional contributions.
Thank you. Thank you for mentioning that. Yeah, they could use more members. We'll keep putting that out there. So now I'd like to go back and begin discussing again some of the issues that were raised earlier in the conversation. If you would please reiterate your questions, either raise your hand or enter them into the chat, and we can start answering those that came up earlier during Dr. Damiano's presentation.
Farla, the first question of somebody who was in the queue, we'll see if they're still on, was Robin. I see that Robin is not on, but they did let me know that they believed their questions would be or looped into the letter that was pulled up. And so we're comfortable with that being prioritized.
Okay, that sounds great. Thank you. I think, Liz, was there another question? I know Aparna had some further comments, I believe. Is that still true?
Yes, so I would first like to ask a clarification question of Dr. Damiano. So the data that has been reported on vaccinations so far, the report that compiles the SSO/healthcare staff Is that just vaccinations that have been administered by Department of Health Services to the Sheriff's Office and healthcare staff?
Sorry, I was trying to unmute my phone. What we used to report was vaccinations on site. Once the health order went into effect for corrections and we had the vaccination verification program, now we're only reporting on the health and mental health and administrative on site, which is where I got that 95% vaccinated number. The rest have exemptions and are tested weekly. The sheriff's office is not using what we call our Qualtrics system. I believe they're using their own personnel, so I don't have access to that data. You can do a PRA to the sheriff's department to get the vaccination percentage from their office.
Sure. So the PRA requests we've submitted to the sheriff's office have been ignored. There have been multiple requests that have not been honored. Most of the requests we were sending for vaccinations, we would get a one-line response and they would redirect us to you. And you, the Department of Health Services and Public Health Department, would give us this aggregate report between Sheriff's Office and healthcare staff. And this was before the health order, so that was an aggregated count. And we also never had a denominator, so we don't know the percentage. So the first big concern, and something I would really urge the board to step in and push for this data transparency, we do need some data, very basic data on vaccination rates for the sheriff's office as a whole. And then we want to see that disaggregated by jail and non-jail staff. Because what I've seen some counties do is they'll report the whole vaccination rate for the sheriff's office, but that sometimes is a lot higher than the vaccination rate for the jail specifically. So having just basic numbers for the entire sheriff's office and then for jail staff and the non-jail staff, I think that's step one. And then getting really detailed data on compliance rates with the July 26th health order, which requires weekly testing for unvaccinated staff. And that's also something we have not been able to get access to.
So I want to clarify a couple of things. The state public health orders for corrections went into effect August 19th with full compliance by, there was a date in October, I believe.
It was October 14th.
Thank you. You're absolutely correct. So that was the full compliance date. So when you send your PRA, or if you have public health do it, I would state for the period now, in terms of getting data, you know, what's their vaccination rate, that sort of thing during this period. Because I think before they were like us, we were just counting our vaccinations on site. Now they're having to get the vaccination percentage, and I do believe they have that for the custody and non-custody and non-sworn that work in the jails.
Okay, so So my understanding of the August 19th health order is that it applies primarily to healthcare staff and to sheriff's office staff who work in a medical setting. So it doesn't apply to all jail staff as a blanket.
You're correct. So the detention order that you're referring to that went in effect and is in effect currently, it's for healthcare, mental health, admin, custody, and inmate workers in the jails. So if you're wanting broadly data about the sheriff's department overall, and then a subset of the personnel that are working in the jails, that would need to be very specific in your PRA request.
Okay, so let me just clarify again, and I'll give you the example of Alameda County Santa Rita Jail. So for the August 19th health order, they have just 8 correctional officers that are required to comply. So these are sheriff's office employees who work in the medical setting, and they have to comply with the order, just 8. And the rest of the custody staff are not considered to be have to comply with that order. But the healthcare staff all of them who work with WellPath have to comply.
Oh, okay. I
But
understand.
the entire custody division is subject to the July 26th health order, which requires weekly testing for unvaccinated staff.
Okay, so I think our county interpreted it a little differently. I believe it applies to anyone working in the jails. They don't necessarily have to work in a medical or mental housing unit in the jail.
Okay, so then this is essentially a mandatory vaccination order for the entire jail staff.
Unless they have a qualified exemption.
Okay. Okay, so then I think we would really want to see what percentage of staff are complying with the order, if that's how the county council has interpreted the
so
August 19th order.
Mhm.
Thank you so much, Aparna. So I'm gonna go ahead. There are another person in the queue. So let's go to Phil, and then if we have any time before our close at 1:30, we can come back to you. Phil? Oh, you're muted.
Hey there. All right. So just being sensitive to time, I'll try and be as brief as I can, but wanted to kind of highlight some of the questions that are published on the Sheriff's COVID dashboard. And some of the policies pertain to kind of nursing actions regarding people who are COVID positive. And it refers to kind of the frequent monitoring of symptoms and oxygen saturations and things like that. And again, some of the conversations that I've heard from people who are inside state that is kind of not consistent, and people are not getting their oxygen saturations checked on a regular basis. And so I was just curious, one, if you had any information about kind of the frequency with which COVID positive people are getting checks. Is that a daily occurrence? I would strongly recommend that it would be, and I've heard that that's not the case. So I just want to make sure that there are efforts to kind of, for quality improvement efforts to make, and quality assurance efforts to make sure that that's consistent. And then my other questions, which we probably don't have time for, would be if you have any data regarding the rates of hospital transfers, kind of what the criteria for hospital transfers are, and then options for treatment within the jail, given the significant burden of comorbid medical conditions. Many of these people would qualify for interventions such as Regeneron and the new molnupiravir, the oral treatment. And are those being offered, and kind of what are the criteria that are offered for people that qualify for those treatments, or would qualify for those treatments if they were outside?
So hopefully I can remember all these. There is criteria on the health checks for individuals in the COVID housing. Most of the people are asymptomatic, but obviously on the positives that are symptomatic, there's more. I don't have the exact criteria on my top of my head for nursing. They do periodic audits of those health checks as a QI tool to provide feedback. I don't have the hospitalizations that have occurred with this outbreak. I believe there's been 3. One was just an emergency department visit, but I don't have them throughout the pandemic. For the comorbid medical conditions, pretty much what we have done is send people to the hospital for the hospital to assess if treatments are needed. I know Dr. Kasiri had sent me last night some information that I shared with the medical director, nursing director, and pharmacy director to look at about what might be possible to do in the facility. So we will be looking at that. I think you're on mute.
Sorry, keep doing that.
Thank you, Sandy. I know you have to leave exactly at 1:30, so I'm going to let you go.
Yeah, another minute.
Just wanted to clarify, especially for the oral treatment, there's no IV needed, and the criteria are very cut and dry for comorbid conditions.
Yeah,
and
she just sent that to us. So
yeah,
we'll be
should be no
looking at
barrier
that.
to do that within, and doesn't require transfer. So
Thank you.
thank you.
All right. Thank you for the questions and for the answers. If there's any other comments, we're going to have a conversation next meeting, so please come with your comments or enter them into the chat right now, and we'll hold on to them. I also want to comment on the issue that in the chat about the jail health subcommittee, the working committee that's produced all this work. We need another PHAD member to join, and then we'll have a spot for another community member. So until we get another PHAD member, we are where we stand with community members. That's according to our bylaws. And Steve Orcan, can you had election next month or something in the?
Oh, I'm just, I think, reminding you of the calendar that if you're going to be thinking about officers for next year, that you're probably going to have to take care of it, have an election next month. Time flies.
Thank you. Yeah. Okay. If there are any other comments, please enter them now and we'll hold on to them or come back next month. And I want to thank everybody, including the public, for the excellent participation and comments and questions and all the work. So thank you so much. And I look forward to seeing you next month. Happy Thanksgiving.
Thanks, everyone.